This was a retrospective study that looked at patients with late relapse DLBCL, so relapsing after 24 months, that got a second round of treatment of R-CHOP-like therapy. Basically, what we do demonstrate is that, first of all, the rationale is that late relapse DLBCL is a completely distinct biology. We know that they share very few mutations with the original diagnosis, and it's thought to be chemotherapy naive. And so we know that the R-CHOP and R-CHOP may have a curative intent potential, and it's also a finite duration therapy. And what we did is we looked at the BC Cancer Lymphoma database and BC Cancer Pharmacy Registry to try to identify all patients who did have a first round of R-CHOP, had a late relapse, and then were treated again with a second round of R-CHOP-like therapy. And what we did see in our results is that we've identified 65 patients. Most of them were older, so a median age of 77 at time of relapse. Most of them had a poor prognostic score. 2/3 were IPI 3 or more. And despite the poor risk features of these patients, they were able to tolerate quite well the R-CHOP-like retreatment. Although some of them discontinued for intolerance or progressive disease as we went along. But we still had an overall response rate of 72% and a complete response rate of 57%. Now, the time to progression, which was our first and primary outcome, was of 55% at a 2-year mark for the entire population. Now, what gets interesting is that when we split according to the timing of relapse, those who relapsed between 2 to 5 years from their initial diagnosis actually had very poor outcome with the retreatment strategy, with a TTP at 24 months of only 9%. However, those who did achieve at least, or actually relapse after 5 years of their initial therapy or their initial diagnosis, were able to get a 2-year TTP of 68%. So I think where it gets interesting is that there's an option of treatment of retreating with chemoimmunotherapy these patients with a curative potential for the patients. Yeah, that's pretty much the bottom line of our retrospective study.